Let's cut right to the chase. Welcome to this high-yield explainer on the updated guidelines for managing necrotizing soft tissue infections, or NSTIs. Whether you're an emergency physician, an internist, a general practitioner, or a surgeon, this explainer is built specifically for you. We're going to break down the absolute latest, most critical protocols on the classification, diagnosis, medical resuscitation, and surgical treatment of these rapidly progressive, life-threatening infections. The clock is already ticking on these patients, so let's dive right in. Here's our clinical pathway for today. We'll cover the NSTI clinical threat, classification and clinical diagnosis, resuscitation and antibiotic therapy, the surgical debridement standard, our summary and key messages, and finally, the main bibliographical references.
Section 1. The NSTI clinical threat.
Look, despite all of our modern intensive care advancements, overall mortality for NSTIs remains brutally high, sitting somewhere between 20 and 30% worldwide. But recent data highlights a massive turning point. Getting a patient into the operating room for surgical debridement within 6 hours of presentation cuts that mortality rate by almost 50%, literally in half. Now, we all know that in a chaotic ED, that window closes incredibly fast. Amidst competing emergencies and boarding issues, it's so easy to lose track of time. But that clock starts the exact second they hit your doors. Recognizing the threat early is your only real advantage. Section 2. Classification and clinical diagnosis. To set the right foundation for management, we've got to mentally separate these infections into two primary buckets. Type 1 infections are polymicrobial. We're talking a dangerous mix of aerobic and anaerobic bacteria. You'll typically see this in patients with severe comorbidities, poorly controlled diabetes, chronic renal failure, or severe peripheral vascular disease. Type 2 infections, on the other hand, are monomicrobial. These are usually driven by group A strep or Staph aureus. And terrifyingly, they often strike younger, completely healthy individuals after something as minor as a paper cut or blunt trauma. Knowing this phenotype right off the bat guides your entire initial systemic approach.
Now, we're all familiar with performing a small bedside incision to look for that classic gray, foul-smelling dishwater fluid, right? Or doing a sweep test to see if the fascia just separates easily with a sterile finger. But here's the trap. According to national surgical standards, the absence of these signs absolutely does not rule out a necrotizing infection. You simply cannot rely on a negative bedside sweep to comfortably send a patient home or delay definitive care. Early signs can be incredibly subtle, and false reassurance here can literally be deadly.
The exact same caution applies to the LR-NID score. Sure, using labs like CRP, white count, and sodium to assess risk can be a helpful data point in your initial workup. But in clinical practice, its sensitivity is highly variable. So the standard is absolute here. Never use a low LR-INI score to rule out an NSTI or to justify delaying a surgical consult. If your clinical gestalt is screaming that something is wrong, trust your gut. Sepsis and NSTIs are clinical diagnoses first and foremost.
Section 3. Resuscitation and antibiotic therapy.
When it comes to resuscitation, the directive from the British Orthopaedic Association standards leaves absolutely no room for hesitation. If a patient presents with evidence of sepsis, the Sepsis 6 protocol has to be initiated immediately. That means high-flow oxygen, drawing blood cultures, checking serum lactate, pushing aggressive IV fluids to combat profound vasodilation, monitoring urine output, and of course, starting early, broad-spectrum IV antibiotics to fight the systemic shock while you're prepping the OR.
Speaking of antibiotics, let's talk about the heavy-hitting empiric regimens based on the Intermountain Health Guidelines. You need broad coverage right now. Option A is your classic triple threat, PIP/Tazo combined with Vanco and Clinda. If you're dealing with a severe penicillin allergy, option B swaps in cefepime. Notice that clindamycin is a non-negotiable staple here. Why? Because it specifically suppresses bacterial exotoxin production, which is what's driving all that rapid tissue destruction. Oh, and our critical note from the guidelines. Never use linezolid as monotherapy for these severe infections. It simply doesn't give you the rapid bactericidal action you need against this threat.
While you're aggressively resuscitating, don't mess up the microbiology. Accuracy here is paramount. First, get 2 sets of blood cultures before you hang those IV antibiotics. Later, once they're in the OR, the surgical team needs to grab 5 deep tissue samples using a strict no-touch technique with separate sterile instruments. These samples have to be explicitly labeled so we know exactly what's from the necrotic zones versus the healthy margins. And please, whatever you do, never rely on superficial wound swabs. They just don't correlate with deep tissue pathogens, and they'll dangerously mislead your antibiotic step down in the days to come.
Section 4. The surgical debridement standard.
All right, this brings us to what is perhaps the most common and frankly the most dangerous pitfall in modern emergency medicine. Let's say your patient is stable enough for the scanner and you strongly suspect an NSTI. Should you wait for a CT or MRI to confirm the diagnosis and visualize the gas or tissue necrosis?
The answer is an emphatic, absolute no. Do not delay surgery for imaging. The guidelines explicitly state that urgent surgical intervention shouldn't be held up by intensive care management, intra-hospital transfers, or scans. Time is tissue. The definitive diagnosis of an NSTI is macroscopic. It's made directly by the surgeon in the operating room when they see that dull, gray fascia and a lack of normal tissue bleeding. Sending a patient to the scanner burns precious time that they simply do not have to spare.
Once the patient is actually in the OR, surgeons follow a very logical three-zone approach to get absolute source control. Zone 1 is obvious macroscopic necrosis with thrombosed vessels. That requires complete surgical excision. Zone 2 is the area of likely infection, where you see induration and tenderness. Even if the skin looks kind of normal, if the fascia underneath isn't adherent, it has to be completely excised. Finally, Zone 3 is the healthy margin. Because these bacteria spread microscopically along the fascial planes way faster than the naked eye can track, standard practice is to excise a 3-centimeter cuff of normal healthy tissue, just to ensure you've outpaced the infection.
But the surgery doesn't end when the patient rolls out of the OR. Post-op care is relentless. There is a mandatory standard that every single patient with an NSTI gets a wound review by the treating team within 6 hours of that initial surgery. If the patient is failing to improve systemically, persistent shock, rising lactate, increasing pressure requirements, it heavily implies you have incomplete resection of infected tissue. That mandates immediate surgical re-exploration. This is absolutely not a wait-and-see situation. You have to go back in and find the source.
Section 5. Summary and key messages. If you only take away a few things from this explainer, make it these 5 clinical pillars. Number 1. Time is tissue. Getting to the OR within 6 hours slashes mortality. Number 2. Clinical judgment over imaging. Never delay the OR for a scan. Number 3. Initiate sepsis 6 and draw blood cultures immediately. Number 4. Hit the infection hard with broad empiric IV antibiotics, specifically a beta-lactam combined with Vanco and Clinda. And finally, number 5. Surgical source control demands aggressive, multi-zone debridement to stop that microscopic spread in its tracks.
Section 6. Main bibliographical references. Everything we just went through is directly grounded in the latest evidence. That includes the 2024 cohort study by Brands and colleagues on imaging pitfalls, the upcoming 2026 Surviving Sepsis Campaign guidelines, the 2025 BOA standards for musculoskeletal soft tissue infections, and institutional heavy hitters like the Intermountain and UCSF clinical guidelines. Pulling these texts is a fantastic next step for your own continuing education.
So I'll leave you with this final provocative thought to chew on the next time you step onto the ward or into the ED. With a literal 50% mortality reduction on the line for patients who get into surgery under 6 hours, is your hospital's pathway really fast enough to beat the clock? Thank you so much for joining us for this explainer, and we will catch you next time.